Good morning and welcome to another session on heart. Now, this time we'll be talking about congenital heart disease, right? And deliberately I've written it like part one because we'll divide it into two parts, the cyanotic and the acyanotic conditions, right? So that's how today we'll be learning the first part, and then day after tomorrow it would be the second part. And yes, we'll be talking about, we'll watch Doppler, CT scan, angiography, right? All those diagnostic radiology images to get a better understanding. Okay, so let's start. Again, this time what I've done is many of the things I have pre-written, right? Just to save time so that we can learn the things more. So here is welcome to congenital heart disease, part one. Now see, whenever we talk about congenital, that means it is right from the birth, right? Congenital is right from the birth, right from the initial stages. That means that in embryology, right, during the stage of development, if there is any defect, if there is any variation, so that leads to all these congenital heart disease. So parallelly, as we'll be discussing any of the condition, we'll have a look at its embryology part also to make things much easier. So it is the deviation, deviation from the normal path, right? So what can really go wrong? A structure can go wrong. There can be some defect in the structure, or there can be some functional loss. Some vessels, they might be obstructed, they might be going on some abnormal paths. So all these things, they will be leading to some defect. Now, because heart is extremely dynamic, right? You know that even when we were learning ECG, right? It is extremely dynamic. We need to see that from which direction the blood is going, where the pressure is rising, where the pressure is decreasing, and that will lead to actually the pictures which we see in radiology. So, and actually those things will also reflect the sign symptoms, right? So thus this is like a very wonderful combination. So when we look at the classification, this is what I was talking about: acyanotic and the cyanotic. Acyanotic means it is like a pink baby, right? It's a pink baby. It's not bluish discoloration like in cyanotic. This is for our today's menu, right? This is our part one. So where we have to focus on two things: volume and pressure overload. This means what? We have to watch for two things. For our today's entire session, we have to watch for just two things. One, in which chamber the pressure is high or low. And this we have to watch with perspective of that when the normal function is going on, right? When the heart is beating normally. And the direction of blood flow. Direction of blood flow. But if you remember just these two things, these two keywords, you'll find that all things, they are extremely easy. ASD is atrial septal defect. So if we really draw the heart, right, like our standard drawing, so this is atria, right? This is atria, atrial septum, right? This is right atrium, this is left atrium. So ASD would occur over here, the septum between both of them. Similarly, this one would be the VSD, ventricular septal defect, right? PDA, you really like that. That is the patent ductus arteriosus, right? You know what is ductus arteriosus, right? Ductus arteriosus. And this one is the coarctation of aorta. It is coarctation, right? Coarctation of aorta. Coarctation means narrowing. These are the four topics which we'll be covering today. And rest of the things, right? That is pulmonary blood flow, that is the TUF, transposition of great vessels, tetralogy of Fallot, tricuspid atresia, truncus arteriosus, hypoplasia, left heart syndrome, all those things we'll be learning tomorrow. But once you have understood this, the part two is going to become extremely easy. Right? Then we'll be talking about some vascular tumors and AV malformations. So let's start with ASD, atrial septal defect, right? Now see, in atrial septal defect, let's let's draw only the atria, right? This is like we are drawing only the atria. And here is the thing. Rest ventricles, they are over there. So right now we are not much interested. It happens like this, that from top, right, a septum starts developing. It is developing all the way it touches over here. This septum, right, this septum which divides the whole thing into two parts, right? This is what is called as the primary septum. Primary septum, so that it's called as the septum primum. Now, one interesting thing happens. This septum primum, as it lands, as it touches over here, from this point, it gets degenerated, right? It is removed. So this is now our septum primum. Now, in order to fill up this space, there is formation of another septum. Second septum starts developing, and it reaches up to one particular level. And very rightly, this would be our septum secundum, right? That's our septum secundum. And this all-time favorite, this is foramen ovale, right? That is foramen ovale. So this is how that foramen ovale is formed. Later on, yes, you know that both of them, they fuse, and once they fuse, so right, it is then in its memory, what we really see, it is called as the fossa ovalis, right? Fossa ovalis, that is what we saw into the anatomy of right atrium when we watched it from inside, which is in memory of foramen ovale, right? But this is how things go into the histology, in the embryology. Achha. Now, as this septum was getting developed, right, from the top, it was coming, say, I'm talking about the septum primum. As it was coming down, right, all the way from the top, the space which is over here, this space, that is called as the ostium primum, right? It is called as the ostium primum. Ostium primum. Then as this septum hits over here, and a new gap which is created over here. So I'm talking about this gap, right? This gap which is created over here. So that is called as ostium secundum, right? Again, ostium is a space, and the primary space and the secondary space. So basically foramen ovale is what? Foramen ovale is ostium secundum, right? It is ostium secundum which is between these, say, two septums, septum primum and the septum secundum. Now, if you really want to deviate from this, so many combinations you can think of. Let's say one combination could be, as this septum primum is coming and developing from the top, it fails to touches this part. It fails to touches this part. So that means there would be a gap, right? There would be a gap over here. This gap would never be filled because this septum secundum is developing from top. So this gap would never be filled, right? So it will lead to what? Atrial septal defect. These are the two atria. This is left atrium, this is right atrium, and the gap or the defect between both of them is atrial septal defect. So it can occur like this, or, well, it can happen like, say, this septum secundum, it develops only up to this portion, plus only up to this point. It doesn't go all the way down. Nothing will happen into the fetal life, right? It would be perfectly fine, because in any case the blood is getting pushed from right atrium to left atrium. No worries, things are fine. The problem will occur after birth, right? So what I'm talking about is, that is, in case it would go like that, say, this would be the situation. Here is the septum primum, and septum secundum developed only up to this point. So now, even if it tries to cover this, foramen ovale will always remain the patent. It will always remain patent, right? So this foramen ovale, when it is there, This is like a defect in the septum, and that is atrial septal defect, right? Whatever the way it is developing, but this is what happens. Now, let's see. Everything would be with perspective of that blood will be going from which side to which side, right? So over here, obviously the left atrium, and this is the right atrium. Left atrium is definitely under high pressure, so shunt means shift of blood will be from left atrium to right atrium, right? This is after birth in adult, or less best is say we say it after birth, right, adult, after birth, right, after birth. As the lungs they open up, that means the pressure inside the right atrium to right ventricle, as the lungs have opened up, so that pressure drops, and left atrium to left ventricle to aorta, that normal circulation starts. So over here left atrial pressure is more than right atrial pressure, so blood is pushed from left to right shunt, and this is the most common thing, right? Now from right atrium it will go to where? It will go to right ventricle. From right ventricle it will go where? It will go to lungs. Now lungs will be overloaded because as such right atrium is already getting the blood from superior vena cava and inferior vena cava, right? And this entire gush of blood, now it is constantly putting load on the lungs, and that is what leads to the second thing, and which is called as the pulmonary congestion. Pulmonary congestion. Can we see it? Definitely we'll be able to see it, and we'll see it within few minutes. Pulmonary congestion, right? This pulmonary congestion is the prime thing what we will see. So everything will be related to pulmonary congestion. So that's why we highlight this, because that would be like our key thing to see in this case, right? Now about the types, well, now it is easy for you to understand. That's secondum ASD, right? Septum primum, but this is what we said, right? This one, when the septum secondum, right? Septum secondum is not really reaching all the way to cover up the primum, septum primum. So that is the commonest one. Septum secondum ASD, almost 70% of the case. And then the septum, then and the primum ASD. So they both comprise almost all. Sometimes in this is even less than that. Sinus venosus ASD, or these are a bit rare. Common atrium is like, this is what really happens. Means primum, secondum, but they fail to develop, or they develop so less that almost the entire space is open. So this is where it is acting like a atrium, common atrium, right? Right and left, they both behave like one only. So that is very rare. Well, statistically more common in females as compared to males, right? Let's watch it here, right? Just for the understanding, right? Pretty clear. This is how it would really look like. This is the blood which will be pushed from left atrium to right atrium. This is our superior vena cava, this is inferior vena cava, right? And that's the wall. So from here it will go, and from here it will go into this pulmonary trunk, and from pulmonary trunk it will lead to lungs, correct? Left lung and the right lung. And that is where the congestion would occur, right? Pulmonary congestion. So this is the whole path. That's how things will really go. Obviously, superior vena cava and inferior vena cava, they are already sending the blood into right atrium. As I said, let's watch the hemodynamics. In fact, we just talked about it, right? But ASD allows a left to right shunt, right? Left to right shunt. From left to right, it will go into the right atrium to right ventricle and to the lungs. But important thing is that on left side we have got oxygenated blood. So it is this oxygenated blood which is now going on to the right side. Right side is already getting from superior vena cava and inferior vena cava carbon dioxide blood. right? As such, it is to be sent to lungs. So now more blood is reaching to lungs, and also oxygenated blood from pulmonary veins and left atrium, it enters right atrium, right? Because that's what we said. This is the oxygenated blood which is going on the right side. Right atrium, right? It is getting more blood from left atrium. This would be enlarged, correct? Then right atrium will say, I can't store, push it to right ventricle. Now right ventricle is overloaded, so that is right atrium enlargement, right ventricular hypertrophy, right? And via this pulmonary trunk, right? Pulmonary trunk. And they will also be under high pressure. So pulmonary arteries, they will be dilated. So this is pulmonary artery dilatation. Dilatation. Right? All because of the pressure, because of more blood. Right? More blood, and which is coming via left atrium. Right? So overall, if you really look at the picture, it is in nutshell, if we say, it is the right heart overload. Right heart overload. Fair enough. Now see, because of this pulmonary congestion, right? Because of this pulmonary congestion, it will generate pressure, right? Because blood is getting collected, and it is not for once or twice or thrice, it is constant. So gradually this pulmonary congestion, right, what it is happening, this pulmonary congestion increases. As it increases, it starts giving resistance, right? It starts giving resistance because there is more blood getting accumulated. So it will lead to back pressure. Back pressure. When it will lead to back pressure, there would be rise. There would be rise in the right ventricular region. In right ventricle, there will be increased pressure. Again, that pressure would be backfired to right atrium, right? So now that is increasing. Left atrium, initially the left atrium pressure was high, right? So shift was from left to right, left to right. But now this is giving resistance. So even if right atrium is having high pressure, left atrium is also having high pressure, how much blood would be transferred? The difference. Gradually you will find that the difference starts decreasing, right? At one point, both of them, they are having the same pressure. Both of them, they are having the same pressure. Same pressure. Are you getting it? It is the same pressure in both of them, and it is because of the lungs have backfired, right? Back pressure, which is getting transmitted from right ventricle to right atrium, and then right atrium is giving resistance to left atrium. And at one point of time, because this pulmonary congestion is constantly increased, a new thing develops. The shunt is reversed. Shunt is reversed. Right? Now the blood is going from right atrium to left atrium because it is the patent in between the space, that septum is defective. So it shifts from right atrium to left atrium. And as it shifts from right atrium to left atrium, this is what is called as the Eisenmenger reaction, right? A very bad thing, very bad sign. When this happens, it takes years, right? It never happens immediately because that pressure has to rise till a state comes when it leads to reversal of the shunt, right? So this is reversal of shunt. So now the shunt will be from right side to left side. Right? Can we see this thing on X-rays? Yes, we can see that, and we'll see, right, that how both the X-rays, they appear different. You don't have to really remember anything. You'll just watch it and you'll be able to understand it, right? So eventually there is pulmonary hypertension and pulmonary vascular obstruction, right to left shunt, and this leads to systemic desaturation. Systemic desaturation. See, very, very interesting. Why systemic desaturation? Initially, to chalo left side was getting bit less blood, but that blood was so pure, only oxygen. Now it is happening that this CO2 rich blood is getting entered into the left atrium. So now this was oxygenated, this is deoxygenated. So now that is what is called a systemic desaturation, and that would lead to cyanosis, right? That would lead to cyanosis because this is like less oxygen is reaching because of the mixture of that carbon dioxide rich blood, and then that's what is called as the Eisenmenger reaction, and the complication of Eisenmenger reaction we'll see. So as we just talked about, we won't be watching it in childhood, right? Because it takes time to develop. Because in childhood, the moment baby cries, so that first cry, lungs are fresh, lungs are good, there is no congestion, so blood will be pushed from left atrium to right atrium. So there is no scope of any reversal of shunts. So that's the reason Eisenmenger complex will not be seen during childhood. Well understood, right? Frequent symptoms in patient with large ASD. Makes sense. Makes sense. Larger the ASD, more the blood is getting pushed. Gradually, it's a pulmonary congestion will be developed fast. Now the pulmonary congestion has developed, right? And it is giving resistance. This leads to first thing first, fatigue. Makes sense, right? Because now there is a lack of oxygen, right? Because mixed blood is getting supplied. So relatively tissues will be getting less oxygen because more than half of the blood, so that is getting mixed with CO2. So much of blood is getting mixed. Frequent upper respiratory tract infection. Complete makes sense because of congestion, right? It is because of pulmonary congestion. Blood is staying over there and leads to all sorts of infections. Failure to thrive. Failure to thrive. Thrive means the growth is slowed down, right? Decreased growth or the stunted growth, right? So over here, as the growth is decreased, right? Growth is decreased, and that is once again due to the lack of oxygen. Mixed blood is which is going on, and same thing, dyspnea, breathlessness on exertion. So that small amount of oxygen what is coming, that is sufficient to go for the routine work, but then as the things develop, right, or in case of exertion, person will be breathless, right? Very classical frequent symptoms. These are the classical symptoms which are developed in case of large AST, right? Now when Eisenmenger reaction occurs, the patient will be developing cyanosis, right? Till this point, the situation was that we were having our good blood was going, right, to the other chamber. Over here, as it increases right to left shunt, so now to that is leading to cyanosis because CO2 has taken over. Fatigue increases and there is exercise intolerance. The same way, dyspnea on exertion, but over here it is total intolerance. Person just can't do exercise, right? And what would be the complications? Cyanosis, bluish discoloration, right? That we, so stroke, stroke can occur, right? Same thing, right? Stroke. There is one more thing, what is called as the polycythemia. Polycythemia, right? I have not mentioned it here, but I'll just write it, polycythemia. Polycythemia is what there is increased RBC, and that leads to clot formation, right? And that can lead to stroke. Then the load on right heart, because this is right-sided overload, right heart failure, right? There will be atrial fibrillation. Atrial fibrillation. That means atria, they start beating at a very high rate to compensate this, right? So fibrillation. Mitral prolapse, right? That is mitral regurgitation, tricuspid regurgitation. So these valves, they are affected. Say for example, say over here, right? Blood is coming over here, and this one is our tricuspid valve, tricuspid valve. But as the pressure is increased, because from here things are going to lungs, right? Lungs are experiencing large pressure, back pressure, and it will start hitting the valves, and the valves will go away. They say, okay, let the blood go in a reverse direction, right? And the atria and the ventricles, they enlarged. But this leads to, say, tricuspid regurgitation and eventually death. But it takes time. Remember, it takes time. It is not an immediate process because it should develop. Now let's see this thing in X-ray, because in one stroke you'll be understanding so many concepts. First thing which is giving us the impression that this is X-ray of a child, right? It is child. Small frame, right? Just the look itself is telling that this is a child. Now in this case, watch for the heart. When you say, is there any cardiomegaly, is there any enlargement of the heart, right? I'm showing you a very easy thing. Maximum width. Find out the maximum width of the heart. Name it as, let's say, B. B. Then figure out what is the maximum width of the chest. Take a measurement, right? Literally, physical measurement. Just measure, right? And let's say this is A. If heart has enlarged more than 50% of the chest width, in other words, when B is more than half of A, that means it is cardiomegaly. Heart is enlarged. Cardiomegaly. Easy, right? Maximum width of the heart, that is B. Maximum width of the chest, that is A. And if the B is more than or equal to half of A, so then it is cardiomegaly. So this is the first point which it is instantly evident, right? You just see it and you know that yes, it is there. Now the second one, what can really happen? What can really happen to the heart? Well, right atrium would be enlarged, right? That is fine, because this is what? This is the X-ray chest PA view. Right ventricle is in front. So even if right ventricle is enlarged, is dilated, right? Even if it is hypertrophied, we won't be able to see it. Because to see that, we have to go for the lateral X-ray chest, correct? Because right ventricle is right in front. And X-rays, they work on the principle of differentiation, right? Whether there is difference in the density. Heart is heart, right? Its entire density is same. So if anything is enlarged in front, we won't be able to appreciate it. But say, what about the right atrium? Right atrium is, instead, we have seen the heart like this, correct? This was our shape, right? Not this, right? That is for different purpose. But this one, and as it enlarges, this one, this curve, this is the indication that this is right atrial enlargement. Easy? Right atrial enlargement just from that curve, right? Otherwise it is like this. This is normal. Right? So not very complicated. This is true. The third thing, right? We'll just write it so that we keep it in our mind, and the hemodynamics, it is followed. So right atrium enlarged, and we have to watch for right ventricular hypertrophy also, but we'll just write that is for lateral X-ray chest, right? That is what should be our next step. The fourth thing, this is so classical, right? So classical, you just watch it and you will never forget it. This is, we said, right, that there is congestion in lungs. So congestion means what? Congestion means there would be more blood inside the heart. that blood would go where? It will go via those pulmonary arteries, and then they will divide, right? So it will be spread across all the way, right, under high pressure. So when we see that those bronchus which are carrying the air, and these blood vessels which are going collectively, they are called as the bronchovascular markings, right, which is a combination of blood vessels and which is a combination of bronchus, right, and they will be shown clearly against the density of each other, right. Normally you see this much up to inner two-third, you see the BVMs, bronchovascular markings. While in this case, you'll find that right atrial enlargement, right ventricular dilatation, right, that has dilated, and it has pushed the bronchovascular markings almost to the end, right. To appreciate this, we just zoom this thing and you will know that how nicely it is seen. I zoom it still further. See, so amazing, so beautifully it is seen. See, these are bronchovascular markings, right? They are, all these are, right? See this, right? All of them. But see how they are going till the end, right? See, they are going till the end. See, going till the end, right? See here, right? I'll now erase them. See, this is the thing. Otherwise, there is a sharp cutoff. From here, you won't be able to see anything. But here, they are seen till this end, right? As I'll be transferring this file, right, you can just zoom it and you'll be able to see it more clearly. So we write one more point over here. And don't worry, today we'll be watching so many X-rays, right? So many that this thing will become completely easy. Achha. So, right. So this was 1, 2, 3. The fourth point is increased bronchovascular markings, BVM, right? Bronchovascular vascular markings, and they are seen all the way, right? And see this, right? This one, this is our main pulmonary artery. So that pulmonary trunk, right? That pulmonary trunk, as it goes right over here, here. So here it is prominent because again the high pressure. So that high pressure starts affecting. So this leads to, see the bulge, right? This one. So this is main pulmonary artery. It becomes prominent, right? It becomes prominent. When this thing occurs, you should not be having any trouble in deciding that this is, you are watching a case in which there is left to right shunt, right? Left to right shunt. The moment you see left to right shunt, immediately you start watching that these bronchovascular markings, are they going all the way to the end? If yes, the pressure is high, right? But this pressure is not getting relieved. Pressure can be relieved in only one state, when the blood from here, it is pushed somewhere else. In this case, foramen ovale closes after, what's your question? In this case, foramen ovale closes after birth or it remains open. After birth, the foramen ovale definitely closes, right? Because as per the normal embryology, right? As per the normal embryology, right? Here it is, right? This one is septum primum, septum secundum, and as soon as the first cry, the moment baby cries, right? These channels, they are open, right? So immediately pressure in the right atrium drops, because pehle to it was right ventricle. From right ventricle, things were going into the lungs. Lungs useless. There is no point in, because lungs are loaded with fluid, right? So they were in fetal circulation. Lungs have got no role. So that's why this right ventricle, which was going out by pulmonary trunk, that pulmonary trunk was sending the blood into the aorta via that ductus arteriosus, correct? Ductus arteriosus. So entire blood was pooled. Whatever the blood which was left out after shunting of this. So this is what happens in fetal circulation. But as soon as baby cries, this pressure drops, because now the blood can easily go into the lungs. So now there is less resistance. So left atrium at that point tries to again send the blood over here, but not possible. The moment it tries to do this flap under the pressure, it closes, right? And this new situation would be something like this. And they are now in proximity with each other because this pressure is high. So as they remain over there, gradually they fuse. And this fusion is our atrial septum, interatrial septum, right? And this space that remains as the memory. Once upon a time there was foramen ovale, right? It is now called as the fossa ovalis. The trouble is when these septum, they are in problem. They are not developed. They have not developed properly, and there is some space, and that space is what is leading to all these complications, right? So foramen ovale closes after birth. Definitely it closes after first cry. That's why first cry is important, because when baby cries, right, lungs open up, that air goes in, right? So the opening due to defect remains open. The opening which was into the fetal circulation was a lifesaver. That opening is a killer now, because it will lead to that passage of blood which is not welcome, right? It should not happen. So we have got, in this case, we got increased pulmonary vascular markings or bronchovascular markings, right? Then right atrial enlargement, right ventricular enlargement. So that leads to cardiomegali, right? And the prominent main pulmonary artery. This thing is also radiologically, it is also called as the pulmonary conus. It is also called as pulmonary conus. So just remember, because over there, sometimes it will be written as prominent PC, prominent pulmonary conus, right? When this thing happens, our diagnosis would be that this looks like ASD, but you will always mention that this is without Eisenmenger complex. Eisenmenger complex. Two things they are supporting it. One, the age of the baby is quite less, right? Eisenmenger complex can't develop that fast, right? It takes some time. And second, the bronchovascular markings, they are all the way till the end. When they are till the end, it means the pressure is building up, right? At one point, when the reverse shunt would start, so that means the pressure in the lungs, they would decrease. So these vascular markings, they will retrace, they will be less. We'll see the X-ray, right? So due to these two things, just remember, one, age, and second, the BVMs, bronchovascular markings, they are present till end, right? They are present till end. Okay. As I said, that we'll be watching some other images also. These are also very interesting things. Yeah, now it is fine. See this. This is color Doppler, right? This is color Doppler. Doppler is based on the principle of sound, right? Just I think last time or just before that we were talking about, right? Doppler. Change in the perceived frequency. Change in the frequency which we feel, right? Exactly like only example which I ever give is of that railway engine. Because I used to, means on railway station, means आँख बंद करके I used to guess कि अच्छा engine कितनी दूर है. Yeah, on Friday. Yeah, that's right. Right. So that dur se engine, right, and then that intensity increases. But same thing I used to wonder that for railway driver it is constant. Yes, right. So that is perceived frequency. Perceived frequency. So is the frequency is increasing, right? Sound is becoming louder, 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 right? Or it is going. Remember when we look in color Doppler, many times this gives a wrong impression that red means it is oxygenated, blue is deoxygenated. No, dost, never. In color Doppler, remember red means blood is coming, blue means blood is going. Right, simple as that. Because in this is here is our probe. Our probe is here, and probe means this is like our ear, right? We are listening in that direction, that acha blood is coming, blood is coming. Yes, so that's why these are computer generated things, right? By the algorithm, if the frequency is rising, if the perceived frequency is rising, it will become red, right? So you can say red means the flow is towards the probe. How easy it is. And blue means flow is going away from the probe. So because that blood which is going, right? So this means a high pitch becoming low pitch, right? So that type of sound. So it means blood is going. And when it is ulta, right, it means blood is coming. That the blood which is coming, that would be shown as red color. Now from the, this is left atrium, this is right atrium, it means blood is coming, it is red. Color Doppler tells this thing, right? So if I change the direction of the probe, if I go on the opposite side, this thing will become blue, right? It will become blue. Let's say Eisenmenger complex develops, so this will turn blue because now the blood would be shifted from right atrium to left atrium. It is going away, same size, same position of the probe, right? Probe means you are hearing from here, right? You are hearing from here, right? So that's what it happens. It is the red color. No way confuse it with the oxygenated, deoxygenated. No, these sound waves, they don't understand any of those things, right? Oxygenated, deoxygenated, they just understand the flow, right? In which direction. So when it is left to right, right, it would be red because blood is coming towards it, right? And obviously from right to left, right to left in this situation, and if the probe position is same, so then it would be blue, right? Probe same position, right? As we'll be discussing many of the modalities, we'll be discussing even the amplatzer, that is how the surgically we correct all these lesions, right? So at any point, if there is any doubt, ask immediately, right? So this also tells us whether Eisenmenger complex develops or not. Very true. That's the thing. That's the thing. As we said that in Eisenmenger complex, there is reversal of shunt, probe position is same, and you will find, okay, yes, bluish patterns, they start appearing, right? And as the complex becomes more and more severe, it will be more and more blue. Makes sense, right? Because now the blood is getting pushed on the opposite side. There is so much of pulmonary congestion, there is so much of pulmonary hypertension that the blood is just going from right atrium to left atrium and patient's ki halat kharab, right? Okay, now this one. This is totally different. This is 2D echo, right? We'll watch 3D echo also, but this is 2D echo. So this is where you use the principle of ultrasonography. Right? Now see the chambers. Chambers are seen, right? You see the anatomy very well. So over here it is clearly shown that we have got this one. This one is ASD, right? This one is atrial septal defect. This one, right? Or let's write it like this. This is the atrial septal defect. This is our interatrial septum, right? This is our interventricular septum, right? This is left atrium, left ventricle, so this is our mitral wall, right? This shadow, right? This shadow, it is because it is at a different angle. Otherwise we could as we change the angle, we'll be able to see it even more clearly. But this would be the location of tricuspid wall, right? Tricuspid will be over here. But the point is, clearly it is showing that this particular atrium, atrial septum, it is devoid. This is a large atrial septal defect, right? Because in 2D echo, you watch the physical structure. Right? So think it like this is anterior, right? You got the idea? This is anterior because right ventricle, it is in front, right? Right ventricle, it is in front. Say when we say it like this is right, this is left, right? This is atrium, this is ventricle, right? Those fingers are ventricles, these are atria. So our classical, right, put your that heart, right, which we normally use, right, whether we are in medical or not. And what would be the position of the heart in our body? Tilt it, right? So now the atrias are back and rotate it. So now see this, right ventricle is in front, right? Right ventricle is in front. Left ventricle, it is forming the left heart border, right? This left atrium, it is pushed quite back, it is almost posterior. And this one, right, this is what? This is the right atrium, right? Right atrium, which is on the upper side of the right heart border. So got it? This is that heart, right? That standard heart, I need not explain, right? And then tilt it and rotate it. Bas, this will give you the complete idea how the things are arranged. Do it by yourself and understand it, right? Do it by yourself once and understand it. This image will make crisp clear, right? That this is the right ventricle, which is anterior, left ventricle, which is forming the left border, right? Left border. This left atria, which is pushed back, right? So it is posteriorly situated, and this right atrium, which is on to forming the right border, right? Right border. Obviously, some portion would be overlapping each other, but this is in general, right? This is in general how things would really look like, right? So this is the right side, this is the right side, and this one would be the left side, right? We have already written interior. Got it? Let's move further. This is 3D echo, right? This is 3D echo. Now in 3D echo, it looks like as if you are actually watching the structure, right? So what really happens in this 3D echo or in CT and MRI, right? It is also called as 3D reconstruction. 3D reconstruction. When we'll be discussing CT and MRI, right, we'll be talking more about it, but just you can say that, say if this is the body, right, and these are the slices you take on CT or MRI, you select a point, right? You select a point, and then you start picking up the images that is called as the pixel. Pixel is picture element. Pixel is a 2D structure. When you start interpolating it with voxel, voxel means it is a 3D structure, volume element. That one is picture element, this is volume element, so that you can create a 3D structure because it is based on the computer calculations. So this is like a, a structure. You take section, right? So in every section it would be, or let's make it like this, right? This is a triangle, you take section, right? So in the first section it would be appearing just like this. In second section it would be, say, bigger. Third, it would be still bigger. Fourth, it would be still bigger. When you combine them, so you'll be able to create, yes, you can even rotate this picture, you can watch it from, because finally though it is 3D reconstruction, right? It has been created by 3D softwares, and that's what you get. It is based on what's called as the algorithms, right? There are Fourier algorithms and there are so many, but they can recreate the picture. So this is where it is seen a large ASD, atrial septal defect. Yeah. One more. This is crystal clear, right, left atrium and the right atrium, and we are watching what's called as the high ASD, right? High ASD, high atrial septal defect. And this is very clear that somehow septum secundum, it has failed, right? This is a very nice 2D echo in which you can really watch the things very properly, correct? You can rotate that picture. This one, that picture which I showed you, that was a static one, right? Otherwise, yes, you can rotate it. Here is another one. Now see, this is again a very classical picture, very classical picture. Let's start with things which you already know. Can you say that there is cardiomegali? Beyond doubt, right? Beyond doubt, you can say, yes, such a huge heart, huge one as compared to the chest, right? As compared to the chest, definitely. So I'll just write 1 over here. I'll write 1 over here. Cardiomegali? Yes, there is cardiomegali, right? No doubt about it. Theek. Let's move on to the second point. What else we watch? Is there right atrial enlargement? Yes, the curve itself is telling, right? Huge curve, huge one. So done. This is point number 2. There is right atrial enlargement. So far, so good, right? So far, so good. Pulmonary conus, perfectly right? Beautiful pulmonary conus. I should not say beautiful because patient is in severe trouble. But from the radiological aspect, we can say that this is prominent pulmonary conus. Three things, so they are crystal clear. Now we watch for that pulmonary markings. Well, pulmonary markings, can we see? Yes, we can see, right? These are the pulmonary markings. See over here, here, right? Here, right? They can be seen. Over on this side also, they can be seen. So we can say, let's write over here, 4 prominent pulmonary markings, right? So far things are good, but we need to see one more thing, and that is it going all the way towards the end? We need to zoom it, right? We need to zoom it, zoom, and see, suddenly we find that no markings over here, right? Or on the opposite side, we find that, see, this area is crystal clear, not a single marking, right? Over here, no markings, right? That's right, perfectly right. That's right. This means, see, as I'll remove this, you'll appreciate it, right? And I think I should remove it so that during practice you can watch it properly. Huh. Yes, right. The look itself is telling that most of the congestion, right, it is in this area. Most of the congestion, it is in this area, right. Rest is all clean. So this is not a good sign, right. This is not a good thing because prominent pulmonary markings. But fifth is decreased peripheral markings. It is called as the decreased peripheral markings, right. Peripheral markings. And when the peripheral markings are decreased, you say that this is ASD plus the Eisenmenger complex. Eisenmenger complex. Right? So distal lung fields, they are now clear. Right? So that is the important thing. Right? Distal lung fields clear. On to the next one now. See, this is CT scan, right? This is CT scan. Today what I have done is that, say, all these say congenital heart disease, they are very interesting, right? Easy to understand at times, but when we see the images, it enhances our understanding. Now see this CT scan. First look, which side is anterior? Well, these are the vertebra. This one is posterior, right? This is posterior, so this has to be anterior, correct? And we watch the patient from its leg side. So this side is right and this side is left. Right? Over here, so it is easy. Heart is on the left side, but when you are dealing with the abdomen, so at that point it is necessary to figure out which side is right, which side is left. So always CT scan images, you are watching as if you are standing on the leg side of the patient and then you are watching. So immediately it becomes easy. Here it is. This is right side, left side, anterior, posterior. So without beyond doubt, you will say which chamber would be this, which is right in front. Well, it has to be right ventricle, right? Which chamber is this which is forming the right border? It has to be the right atria. Easy. So which chamber is that which is absolutely on the posterior side? Well, posterior, so this is left atria, right? And which chamber is that which is forming the left side of the, this is the left ventricle. Wonderful, right? And here it is. What we are watching over here, this is interventricular septum between two ventricles. And what we are watching over here is the interatrial septum. Let me zoom it. Interatrial septum. And there we see the huge gap, this gap. Right? I'll remove this line, but this is the gap, and that is the atrial septal defect, right? So that's how the blood would be going from left atrium to right atrium, right? One more thing which you should know, this is left ventricle. Left ventricle is like a big boss, right? Thick, big boss, right? So thick walls, right? So this is left ventricular musculature. Right ventricle is as such not as thick as compared to left ventricle, but over here, look at the walls. Almost same, almost same. Thus, we are watching right ventricular hypertrophy. We are watching right ventricular hypertrophy, right? And that's what, and even the looks itself, even the looks, this is like a cross section. That cross section is showing that if this one is left ventricle, so almost same is the right ventricle. In reality, left ventricle is much bigger, right? Much bigger. So this is right ventricular hypertrophy when the musculature has become powerful, become thick, and at the same time, right ventricle is enlarged also, right? So these are the two things which we really can appreciate, right? I'll just remove these black lines so that you can always watch. Fine. So this is where And what instantly, which type of ASD is this? Which type of ASD it is? Without fail, instantly you will be telling that this is the secondum, right? This is the secondum. From the top over here, the another one was supposed to come, another septum was supposed to come and cover this up, cover this up. He has not come, so that's why septum secundum is not at all seen. So you will instantly say without any doubt that what we are watching is secundum, secundum ASD. See how easy things are, right? Not at all complex to it. Now see, right? It makes sense. And trust me, as you will start watching more and more, right? I'll give you several examples. As you'll start watching more and more, things will become easier and easier. The only thing is your brain only watches those things which you really know. Brain will watch only those things which you really know. It won't watch things which you don't know. Right? Yeah, mostly all are secondum cases. Because you know the reason. 70% of the cases, right? They are secondum. It's the most common thing. You know? Ha, this is now you'll feel like as if now the cardiology class has started. Now this is what is called as the Amplatzer. It is called as the Amplatzer. It is called as Amplatzer. What Amplatzer is, this is the septal occluder. Right? I'll write it. Amplatzer septal occluder. Now this one is ASD, is for ASD. Similarly, there would be for VSD, right? So we have to identify between both of them. But things are easy, very easy to understand. This is the gap, right? And we have to fill this gap. This is high pressure on this side, that is on the left atrial side. This is high pressure, right? So we have to just seal it properly. And this is the right atrium, which is low pressure. So there would be a smaller one, right? The thickness of the septum, interatrial septum, is relatively less. It's a thin wall, right? As compared to interventricular septum. This is a thin wall. So this is a thin wall. So that's why we'll be making something like that. The middle portion should be thin. This portion should be big enough to cover the left atrial side. This can be relatively small because it is to be plugged on the right atrial side. And this is for ASD. What you are watching is ASD, Amplatzer septal occluder. Watch this. This is thin, right? Thin middle portion. That is thin, right? This side is for left atrium. This side is for right atrium, right? When you put it into the body, when you have placed it inside, right? And after that, you have done the aortography. This is the aortography. It is post procedure aortography. So here is the left atrium and this one is the right atrium, this side. So when you have injected the dye, see this all black, right? That is the contrast media, right? That is the contrast media. This contrast media is not at all crossing this Amplatzer, right? This one is our Amplatzer. So this is all clear on this side. This means that procedure has been done successfully, right? There is no flow via that ASD into the right atrium, right? This is right atrium. There is no flow into the right atrium. So this is how it looks like. And this is the amplatzer, the real amplatzer. See the middle portion, this middle portion is quite thin, and this is a smaller one that will remain towards right atrium. This bigger one will remain towards the left atrium, right? With this, now we move on to the VSD, ventricular septal defect. Once you have understood this, now the things will go pretty fast. You'll find it very easy. For the ventricular septal defect, I would take a minute for this small explanation. In embryology, have you ever wondered that pulmonary trunk, right, it goes like this, right, and then aorta in between, right? Kya khichdi bana ke rakhte hain, right? Aorta and pulmonary trunk, right? Why it's not so that crystal clear, right? Pulmonary trunk on one side and the aorta on the other side, right? Why it is coming anteriorly and then going back and in between pulmonary trunk and then giving to pulmonary? The reason behind it is that initially there is a common tube. During embryology, it is a common tube. And then there is a formation of spiral septum, right? You have to visualize it like this. It is like a spiral septum. Spiral septum. So that septum as it develops inside it. Inside it, right? As it develops, there is formation of one tube, right? And that tube is your pulmonary trunk. Now, rest of the portion, whatever is remain, right, that forms another tube, right? And the surrounding areas, they are resorbed. And that one becomes the aorta. So now they both are separate, right? They both get separated. But this is because of this, the game is spiral septum, right? It is the spiral septum. Very interesting thing, how it rotates. And so in ventricular septum, because this is a large area, right? Big one. So there are three things which we need to know. One, this portion, right? This one, as it goes from right atrium to right ventricle, right? Right atrium to right ventricle, because there is right atrium, from right atrium to right ventricle. So this would be our inlet. This is our inlet septum. Inlet septum. Because see, the whole septum, one portion which is near the superior vena cava, inferior vena cava, right? And then from the atrium, right atrium, it is coming into the right ventricle. So that is our inlet. From here, there would be the outlet. From outlet, so this would be the outlet. This would be the outlet septum, where the output vessels will be going, right? Whether this is like pulmonary trunk or this is aorta, but they are near the outlet septum. And then the lower portion, this lower portion is what? Lower portion is our trabecular system, right? Trabecular means those thick muscles which you saw, those complex, right, structure. So that is what is called as the trabecular muscular part, right? Trabecular or the muscular part. It is in fact called as the muscular only, right? You can say trabecular or you can say muscular septum. So it is this septum thus which is divided into three parts. Near the inlet septum, right, this is quite thin. So if the ventricle is defective in this inlet septum, right, remember, if the ventricle is defective in this inlet septum, it is called as the perimembranous VSD, right? Ventricular septal defect. Perimembranous ventricular septal defect. It would be near which wall? It has to be near tricuspid wall, right? So near tricuspid wall. Okay, so that is inlet, right? Just for the sake of understanding, right? I'm marking it 1 so that there is no confusion. Outlet septum. Outlet septum, either it is just at the root, just at the root, just over here, right? Let me use the red pen. This is over here. This is the almost at the junction from where those outlet vessels they are going, right? Or it is at this new location which is slightly lower, basically outlet septum. So this part is called as the this one, right? Okay, this, it is called as the sub, because they are just underneath the arteries, so subarterial VSD. Easy, because over here it was membranous, perimembranous, very thin, right? And this is just under the arteries, so subarterial VSD. If this much is clear, third one to is you don't have to even remember, right? It is called as the muscular septum or the muscular VSD, when it is in that portion, muscular VSD. So these are the three types. When they say, okay, this is perimembranous VSD, or it is subarterial VSD, or it is muscular VSD, no big rocket science. It is just inlet, outlet, and the thick musculature part, right? So watch it over here. See, beyond doubt, right? You'll be able to see it very easily that here is this is interventricular septum, and this is the defect. See, this is the defect, right? This one is the defect, correct? So that is a sort of subarterial, right? Because see, aorta, pulmonary trunk, they're just, it is just underneath that. So this is the subarterial, right? So this is a real specimen, right? The dissection from the real specimen. Now let's watch it like this. Beyond doubt, right? This one would be what? This one would be, right? It is lower. So it has to be muscular VSD, right? So easy, muscular VSD. Yeah, this is what, right? Again, we are watching a 2D echo, right? We are watching a 2D echo. In 2D echo, what we watch is, this is the right ventricle, this is the left ventricle. So this would be the left atrium, this would be the right atrium, right? So we are watching at an angle, and over here, see, it is quite low, right? This one, right? This one. The gap in between this one is interventricular septum. The gap is quite low. So this is, when it is low, so we can very well say that this is a low VSD, but we want to be more specific. And when as it is low, beyond doubt it has to be muscular, right? So we can say it is low muscular ventricular septal defect or trabecular, right? If you want to be more scientific, you can say low trabecular VSD. Done, right? So that's what you really watch in this. So far, it is fine, but sometimes it happens like this, that the septal defect, it is not one hole, but there are multiples, right? This is what is called as the multiple. This is a very tricky case, right? Multiple muscular, right? Multiple muscular, because it is lower ventricular septal defect, right? Multiple muscular ventricular septal defect. And the biggest complication in this case is that the occlusion is difficult. Occlusion is difficult. It's not impossible, but it is usually difficult. If you really dissect this, right? If you come across such heart and if you dissect it, right? This is the specimen which is from the Anatomy Museum, and this is what is called as the Swiss cheese cake appearance, right? Or the pattern, right? Those dot, 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 that paneer, right, in which there are dots like that type of appearance, right? This one, right? This is literally a very fine specimen showing ventricular septal defect, right? Now, see this. This is our 2D echo, right? Now, so you are master in this, you know it very well. See how wonderfully you can really see that multiple VST, right? Left ventricle, right ventricle, and thus this is a case of multiple VST. And yes, you are right, multiple trabecular VST or the multiple muscular VST. Right. First look that you know that this is a kid, right? And what you are watching in this case is two major things. Beyond doubt, you will say cardiomegali, no doubt about it, right? Heart is massively enlarged heart, so big, right? So cardiomegali is something which we write instantly, that there is cardiomegaly. When there is cardiomegaly, the first question comes. Cardiomegaly, you said, is fine. Which chamber is enlarged? Right? Which chamber is enlarged? Can you appreciate one that over here nothing like that? Pulmonary conus is not prominent. It is almost straight left border. Left heart border is straight, right? See this? It is almost straight, right? Straightening of left heart border. The moment you say this, right? So this is straightening of left heart border. Wonderful, right? That means it is the otherwise, so it happens like this, right? This left atrium is over here, left ventricle is over here, left atrium, and this was the pulmonary conus. Left atrium, when it is enlarged, it bulges, and it fills up this space. So when it becomes E, left atrial enlargement, right? Yes, it happens in case of mitral stenosis also, right? It happens in case of mitral stenosis also. But in mitral stenosis, it happens like that outlet is rigid. So that's why left atrial has to do the dumbbell exercise to make himself strong so that blood can be pushed through that narrow hole. So in the process, left atrial becomes enlarged. Over here, things are different, right? Over here, things are different. So we'll see that what really happens. But left atrial enlargement, that is atrial enlargement, that is confirmed, right? At the same time, it is not only left atrial enlargement, even the left ventricle is also enlarged, right? Left ventricular enlargement or hypertrophy is also there. We are interested in the most important part, bronchovascular markings. Can we see the bronchomuscular markings? So good are they seen, right? All those pulmonary markings, right? Or I say pulmonary, that is something which is related to lungs. Pulmonary markings, are they there? Yes, they are. And let's zoom this thing. See, I need not even say, right? See how good. All the way till the end, they are seen all the way, right? I'll just remove all of them. See. And as I unzoom it, you'll start appreciating it better, because sometimes you have to watch the x-rays from a distance, right? See, can see, right? They are going all the way up to the distance, correct? So that is showing increased pulmonary markings, right? And when it is increased, so we know that Eisenmenger complex is not there. This is definitely left to right shunt, but no Eisenmenger complex, right? No Eisenmenger complex. Now let's see this in contrast with reflex to this. You can say that, are we findings now? Quickly we say cardiomegaly, yes, right, it is there, right? So this is one, cardiomegaly is there. How about the right atrial enlargement? Okay. How about left atrium and left ventricular enlargement? Yes, it is there because straightening of the border, right? So this is 2, this is straightening of the border, this is 3, that is fine. What about the prominent? Yes, they are quite prominent. So these are the prominent markings, prominent pulmonary markings, prominent pulmonary markings. ठीक. What about the, are those markings going all the way till the end? Now over here we find that over here too they are going, but on other side they are not seen. See, some of this area is seen very clean, right? So this could be query Eisenmenger complex, or the beginning Eisenmenger complex, the beginning of Eisenmenger complex, right? Not full developed because some portion is getting seen. Now watch this. See, what do you see? Straight away, first thing first, right? You find that the main pulmonary conus, right? Pulmonary artery, right? Main pulmonary artery is prominent, right? Cardiomegaly, well, we can't say much about the cardiomegaly. There is definitely enlargement of the heart, but not as bad as which was previous one, correct? This is, but the bronchovascular markings, they are classically absent over here. See, they are only up to this point, nothing over here. Similarly, on the opposite side, right, as we see it up, see, bus absolutely up to this point, nothing seen over here, right? So distal markings, they are totally absent. So this tells that the distal markings, right, distal markings not present, right? Heart definitely enlarged, because if we measure, yes, it would be coming as cardiomegaly. Cardiomegaly is there. We are watching main pulmonary artery is prominent, right? This one, that is prominent. We are watching towards what is Eisenmenger state, right? This is the Eisenmenger state. An Eisenmenger state, as it develops, it leads to reversal of the shunt, right? Reversal of the shunt. When it is VSD, right? When it is VSD, so it means ventricular septum itself is thick. So there has to be a thick middle portion into that amplatzer, and then on both the sides, because it is a big gap, both the sides, they should be big one, right? See here, and you know it, right? So this is the amplatzer VST occluder, right? This is amplatzer VST occluder. How will you differentiate? One differentiation, that middle portion, right? Middle portion is thick. This is first point. And second, right side and left side, they both are same, right? Not like that ASD, in which the right side was smaller. So same, so right is equal to left, right? This right and the left, they both are same, and the middle portion is thick. Instantly you will come to know that this is Emplatzer VSD, right? So VSD will do what? Left to right shunt. It leads to causing pulmonary artery, left atrium, left ventricular dilation, because now it is pushing the blood, right? So on through that defect will lead to pulmonary hypertension and pulmonary vascular obstruction, because finally the blood is landing into the pulmonary system, right? This is the right ventricle. From right ventricle it is going into the lungs. So whether the extra blood was coming from the right atrium via the atrial septal defect, or it is coming via left ventricle via ventricular septal defect, finally though it is going to lead to that pulmonary congestion. So this is bound to develop in any of the left to right shunt, right? It will definitely happen. So when it is from right to left, it leads to systemic desaturation, cyanosis, and all the complications what we talked about, they appear, right? So symptoms, small VSD does not cause any symptoms, because small amount of blood, if it is going from left side to right side, it won't matter much, right? Because it won't be creating any of the pulmonary congestion. But when it is large VSD, it leads to congestive heart failure, right? Because of poor or small frequent feeding, right? Failure to thrive, same what we talked about, right? Tachypnea, right? Increase breathing, more breathe, right? Person would be making shallow breaths, respiratory infection, all because of that pulmonary congestion, fatigue, dyspnea on exertion, we talked about it. And as Eisenmenger reaction develops, patient develops symptoms and complications of Eisenmenger reactions, right? Now we talk about patent ductus arteriosus. So very quickly, we know this part, right? This one. So this is our pulmonary trunk and our left pulmonary artery and the right pulmonary artery, main pulmonary artery, and on top of it we have got that aorta, right? Arch of aorta, and there is a development of a duct. This particular duct, in case of fetal circulation, it is of prime importance, because almost entire blood via foramen ovale, which will be landing into the left atrium, from left atrium to left ventricle, and from left ventricle, right? This is going the into the aorta, right? And whatever the blood which has bypassed, which went into, say, right atrium to right ventricle to pulmonary trunk, so then why to waste this blood? That blood will reach aorta via ductus arteriosus, because later on, as the placenta is removed, prostaglandins will go away, right? This thing would shrink, right? Thing would shrink. This thing won't shrink under the pressure, right? It will take few hours before it would shrink, because it should really get the signal of that no prostaglandins, because it is released by the placenta. As the prostaglandins go away, right, this thing would shrink, and finally it will remain as the monument in the form of ligamentum arteriosum, right? But when it is patent, when it is not getting obstructed, now starts the shunting process, right? That is the patent ductus arteriosus. Here it is. This is the photograph, right? So main pulmonary artery, right, which will divide, and we have got this aorta over here, right? And then there is brachiocephalic, this is common carotid, left subclavian, and this is the junction, right? This is the junction, that is our ductus arteriosus. Wonderfully seen. See, over here, this is aortography, right? Aortogram. We have, this is the descending aorta, right? DAO is descending aorta, right? It is descending aorta. So as you inject the dye, see the dye is this contrast media. Is going all the way from here, and it is going into MPA. MPA is main pulmonary artery, right? It is main pulmonary artery. Now you can watch that this if I really draw this, see it is pretty big. It is pretty big, right? What I have drawn is this one. This is not only big, right? It is quite long, and tortuous. Patent ductus arteriosus, right? Pretty long. The method to seal it, right? How can you really seal it? There is a detachable coil for small PDA, right? Small PDA, so you just insert this coil sort of thing, and then blood will circulate, and finally it will clot it, stop it. Or you can use the Amplatzer duct occluder, this one. This is Amplatzer, but this Amplatzer is slightly different, right? The walls and this opposite side, right? That is, one side is bigger, second side is smaller. Quite similar to ASD, but bit different. This middle portion is thicker. Hemodynamics, initially PDA allows left to right flow, right? Left to right flow, because aorta is under high pressure. So causing pulmonary artery, left atrium, left ventricle dilatation, right? What does Amplatzer? Amplatzer means occluder, something which stops, right? It is name. So if large PDA remains open, then it leads to pulmonary hypertension, right? Large pulmonary hypertension, pulmonary vascular obstruction, and then as the pulmonary congestion starts increasing, it can lead to Eisenmenger, and then it leads to systemic desaturation, cyanosis, and all the complications. Now you know it very well that somehow, anyhow, if the blood goes on the opposite side, right? And what were the major complications? Major complications, they were like cyanosis, right? This was there. And then it leads to polycythemia, right? Polycythemia, more RBCs, right? Increase RBCs, which can lead to clot, and that clot can lead to stroke, right? Very common. Then the right heart failure, right? This is what it can be. Then a very common thing, that is atrial fibrillation, right? Atrial fibrillation. And eventually valves collapse, right? That is the mitral regurgitation, tricuspid regurgitation, and the death. And yeah, very good. And the frequent upper respiratory tract infection, right? So these are very good, right? So these are the common complications. We now move on to the last topic, and this is the coarctation of aorta. Very easy topic, but just you have to understand one classical thing, and you will be very happy to see one X-ray, because you'll be able to diagnose it. It would be like a spot diagnosis. Seconds, and then you know that, okay, it is this, right? Coarctation means narrowing. Coarctation is narrowing. Two types, infant type and the adult type. What's the difference? Very easy difference. Very easy. If I draw it like this, right? This is aorta, right? Over here, now so you know it, that what we are talking about. We are talking about the pulmonary trunk. And then coarctation is this, that is, there is narrowing. So this is COA, that is coarctation of aorta, right? This coarctation of aorta. So now over here, this anatomy to is, you are so good at it, that this is the brachiocephalic trunk, and then this one is like left common carotid artery, and we have got left subclavian artery, right? And then this leads to right, and the right common carotid and the right subclavian, etc. You know that, right? This one is aorta. I changed the color. For infant type coarctation of aorta, narrowing after aortic arch but before ductus arteriosus. So it means if the ductus arteriosus is here, right? So what we are watching is the infant type. Narrowing is after aortic arch. Yes, this aortic arch is over, right? And before ductus arteriosus, this one is the ductus arteriosus. So when the narrowing is at this point, will it make any difference? Should it make any difference? Well, the very amazing difference. Wherever there is narrowing, it means the blood has to struggle to pass through that narrowing. It means there would be increased pressure on the back side and there would be decreased pressure on the opposite side because less blood is going on the opposite side, right? So over here, can I say less pressure over here and high pressure over here, right? High pressure. Now tell me, this brachiocephalic or common carotid or subclavian, they are supplying blood to what? In general, they are supplying blood to upper limb and head and neck and brain. Am I right? Right? Upper limb through subclavians, head and neck, brain through carotids, right? It is going up. And this descending one, when it is going down, it will go all the way to supply to abdopelvis, pelvis, and lower limb. Theek? Very, very easy. Due to this, lower extremity cyanosis. So how easy? Nothing up head and neck, so they are enjoying the blood, but lower extremities, they are, and it is present at birth. Now see, there would be problem in the abdopelvis region also, but lower extremity cyanosis, because that is easily seen. So that's why it would be easily seen whenever you see this case, that only cyanosis in the lower limb, right? While the upper limb and rest everything is fine. Immediately think of that this is the infant type of coarctation of aorta, right? And such patients usually do not survive, right? They do not survive. This is associated with when we'll be learning endocrinology. At that point, we'll be talking about that in Turner syndrome, why in female with the X0, right? X0. So in Turner syndrome, why it is associated, right? But right now, just remember that it is associated with the Turner syndrome. When we talk about the adult type, right? The adult type. In this, in adult, there is no DA, no ductus arteriosus, right? There is no ductus arteriosus, because if it is present, so then it is arteriosus, because if it is present, so then it is a dual complication, right? So we are taking individually. So there is no ductus arteriosus. So that means there is no mixing of blood, correct? There is no mixing of blood, because in infant, what was happening, the ductus arteriosus was present. So whatever the blood which was coming, it was again, right, the mixed blood which was getting pushed, and it was less blood was going. But here what happens is this, the upstream situation. Now this is the thing, this is what is happening, right? This is narrowing, and this is the upstream. This is upstream, this one is downstream. Now in upstream situation, there is increased pressure in upper limb and head, right? Upper limb and head. And for the brain, there is circle of Willis, right? For the blood supply, it is the circle of Willis. Now this is extremely delicate structure, right? All those vessels in the brain, they are quite delicate. When such high pressure, this high pressure would be transmitted up, depending upon the coarctation, well, actually. But if it is severe, so it will lead to transmission of that pressure up. When the pressure, high pressure is transmitted, it will lead to aneurysm. That means the blood vessels, the wall of the blood vessels, they are thickened. Means they are thinned out. They dilate, right? They are dilated. When they are dilated, they are prone to break, prone to rupture, right? This is what is called as the Barry aneurysm. So in circle of Willis, those vessels, their walls, right? Their walls, they dilate, right? They thin out. Aortic dissection, when the wall itself, the inner wall of the aorta, right, that is peeled off, that is broken. Aortic dissection. Similarly, aortic wall is affected, right, because of the back pressure. What about the downstream situation below? In downstream situation, there is decreased pulse in lower limb, right? Less blood is going, so obviously weak pulse, right? Claudication, as the person walks, he starts getting pain, right? This is a typical thing, right? Because it is as good as exertion is leading to pain. So, and that is due to lack of oxygen, right? Decreased kidney perfusion, because when this descending aorta goes down, right, it also gives to those kidneys, right? It gives to those kidneys. So there is renin, angiotensin, aldosterone is affected, and that will lead to hypertension, because kidney will say, less blood is coming, right? So we need to maintain. So it will lead to shrinkage of vessels, because so that the pressure should be properly maintained, and it leads to this hypertension. Now, treatment could be, say, this is like, if this is the narrowing, so surgically it can be corrected, right? Surgical correction, or the balloon dilatation. So balloon is inserted, and then as it dilates, it creates the space, right? So these are the treatment. Now I'll take you to a small, just 2 minutes now. This is arch of aorta, right? Yeah, sort of stent. That's right, sort of stent. Now this is arch of aorta. Arch of aorta, as it goes down, right? This is what is called as the descending aorta. From descending aorta, these are, we have seen this thing, right? Posterior intercostal arteries. True, right? These are the posterior intercostal arteries. All the way from third to ninth, right? Third to ninth, right? They are appearing. What about the anterior one? Well, one of the branch, right? This was what? Subclavian, right? Because brachiocephalic, and then brachiocephalic, it leads to that subclavian artery, right? This is the right subclavian artery. From subclavian artery, right, there is, it comes down, and this one is what? A long one, and that is internal thoracic, right? Internal thoracic artery. And from this internal thoracic artery arises anterior intercostal arteries, right? And these are the things. If this is the rib, right, so we have seen that just at this lower portion, right, there is a groove through which those intercostal vessels, they run, right? Vein, artery, and now vein, artery, now, right? Vein, artery, now. So vein, artery, now. So these arteries, right, they are running over there. Now, whenever there is obstruction, now see what happens. There is obstruction, there is coarctation, right? There is coarctation. When there is coarctation, this means this is under high pressure. This is upstream, is under high pressure. That high pressure is transmitted. It goes to this subclavian, right? That transmission, it goes to interthoracic. It reaches over here, and then it goes to anterior intercostal. These vessels, they are under high pressure, so they are pulsatile, right? They are pulsatile. So even on one patthar, pani ki boond dal karo, then it breaks, right? It will lead to formation of that, right? That dent, right? It will be like this, right? It will be like this. Constant hitting. So these are, right, the classical word which you must remember. It is pulsatile, tortuous, intercostal arteries, right? These are or tortuous pulsatile intercostal arteries, right? Now they will lead to what? They are just underneath the rib, tuck, 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 right? They'll keep on hitting, and this is what I drew over here. It is called as the inferior rib notching. This is like a spot diagnosis. You watch it, and instantly you say that this is coarctation of aorta, and nothing else can it be. See here, right? Just have a look at it and you will know, yeah, it is there, right? I'll put the marks. See this. See this. Very nicely, right? See this. Right? See, can you this and this inferior rib notching, right? Otherwise, the whole rib that should go straight, right? This is inferior rib notching. So when we see the best which is seen is this. I'll zoom it. See, I'll remove this so that you can see, right? As you draw, and see, you find as if something has broken. Same way over here. As you draw, something is broken, right? As you, here it is a bit difficult to appreciate, but still it is seen. It is, sorry. That's inferior rib notching. So that's the case of, so it causes depressions in ribs. Exactly, right? It is like, see here, see, I just noticed this one. See this one, right? Here again, it is so good, ekdam prominent, right? So these are the inferior rib notching, and that's the diagnosis that this is coarctation of aorta. Right. So that's it for today. Right. Tomorrow we'll be talking about the second part of congenital heart disease. Right. Day after tomorrow. Right. Thank you so much. And I'm uploading this file into our shared folder, so you'll get it within few minutes. Right. Thank you and see you next time. Bye-bye.